everyone, and welcome to Preemie Chats. Preemie Chats is a program for healthcare professionals and parents to talk about what matters most to us, to explore new ideas, and to learn together. I'm Leah Whitehead. I'm the mom of a preemie and a former journalist, and I'm happy to be your host today, coming to you from Halifax, Nova Scotia. Preemie Chats was created and is put on by Canadian Premature Babies Foundation, also well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or family, I'd invite you to head on over to CanadianPreemies.org, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. It's important to note as well that all of those resources you find are free to use. And so please head over to CanadianPreemies.org and explore everything that's there to help. Today's session is live, so please bring your voice to the table, leave comments and questions, and we will try to address them today during the program. It is through rich conversations like these where we advance practice and we learn together. So please participate and let us know where you're watching from today. Now on to today's topic. It is estimated in Canada that 6 out of every 1,000 babies will experience hypoxic ischemic encephalopathy, or HIE. In its most basic explanation, HIE is a condition that occurs when brain cells are starved of oxygen. This deprivation can cause permanent injury and affects the central nervous system. Today, we're going to hear from pediatric neurologist Dr. Anna Cristancho, who will discuss common therapies used in HIE today, and she'll also summarize some exciting new potential therapies and outline areas of opportunities for developing new interventions. As I mentioned, Dr. Anna Cristancho is a pediatric neurologist with the Division of Neurology at Children's Hospital of Philadelphia in the States. Since 2018, she has clinically specialized in fetal and neonatal neurology. Her research lab is interested in understanding the molecular pathways important for recovery from prenatal brain injury, with the goal of developing novel interventions that can be used throughout the lifespan to improve neurodevelopmental outcomes. Welcome, Anna. It's great to have you here today.
Thank you so much for the invitation. It's a pleasure to be here.
I'll let you get right to your presentation. I know you have a lot of ground to cover.
All right. Thank you so much. And thank you for anyone out there listening. I look forward to your comments. All right. So I don't have any disclosures. And today I'm going to talk about a few basic topics. First, discussing what exactly is HIE, hypoxic injury, that occurs in the neonatal period and the prenatal period as a process of how the injury evolves and how people recover. We're going to talk about current therapies, of which there are limited therapies of therapeutic hypothermia and supportive care. And then I'm going to spend a lot of time talking about kind of some recent and upcoming trials to talk about where the direction people are going. And I don't have any specific things to tell you about what exactly the future directions are going to be, but I'll tell you the approach that we're thinking about in the lab. So that way to see where other areas we can actually intervene. And you'll see what I mean when I go through it. So to put everyone in the same definition, HIE is very common. Lee already mentioned how it's 6 in 1,000 births in Canada. It can occur from a lot of different things. Acute hypoxic ischemic encephalopathy is something that's typically talked about in term infants. That being said, it can occur in premature infants. It's just much harder to diagnose. It has a very specific clinical diagnosis that has to do with the exam of the neonatologist, usually when child is born, as well as looking at lactate levels and acidosis. And I won't go into specific diagnosis today, but part of that is why it's sort of more skewed towards term infants. And there can also, in the acute period, it can be due to things like placental abruption. It can be due to a uterine rupture. It can also be due to nuchal cord entanglement or shoulder dystocia, and the baby gets stuck going down the birth canal. But there can also be acute on chronic, where during the course of the pregnancy, there may have been some reason for chronic hypoxia, such as potentially some kind of placental insufficiency, so high blood pressure, diabetes, things of that nature that end up leading to it being much harder to then on top of that, having one of those placental abruptions and having acute on chronic injury. And oh, sorry, it got a little bit messed up here, but it's actually the incidence worldwide is over 1 million kids a year. And so the majority of those kids are in underserved, low middle income communities in Africa and Asia. But about 40% of those kids will go on to have some kind of neurodevelopmental disability, which can be things like cerebral palsy, autism, epilepsy, and learning difficulties. And so as far as the scope of the problem, it's quite large and something that we definitely need to address. So to understand what's going on, then we really have to understand the phases of injury. And so at the time of birth, you end up having a hypoxic insult that will happen right before birth usually. There are about 3 phases of injury, including having a kind of latent phase that's between the primary and secondary injury phase. But essentially, here you have the time periods in which they happen, in which you have the primary injury phase happens in the first minutes to hours after the injury. Then the secondary injury phase is in the hours to weeks after the injury. And then really what I call like kind of a recovery phase, a tertiary phase, that's really the rest of the life of the child as the brain continues to develop on top of what was an injury that happened early on. And the tissue injury components haven't happened 2 big peaks. The first peak is in this primary phase and the second peak is in the secondary phase. And what's causing this? So part of it is oxidative stress. So basically, if you have low oxygen, it's causing stress upon the cells. In the secondary phase, when you have a lot of stress and low oxygen on the cells, then the organelle, the mitochondria that need to respond to the oxygen, have a really hard time and start to fail. This starts to lead also to a cascade of increased inflammation, where you have the immune cells coming in to try to clean up what's going on. And this is where you end up having cell death. And this is why you end up having 2 cascades of cell death, the first one and the second one, which is in the secondary injury phase, which is much bigger. And that's where you end up having the majority of the tissue injury. As far as what we can do for it then, so what are the current therapies and how do they correspond to these different phases? And that's how I'll be organizing most of the talk. Therapeutic hypothermia is the most common, is really the only approved and most common treatment for HIE. It occurs here between this first and secondary injury phase and what's called the latent phase. And essentially the point of it is to try to stop some of this mitochondrial failure as inflammation to try to reduce the amount of burden of injury that happens in the secondary phase. So what exactly is it? It is for children who have moderate to severe encephalopathy, so not for the kids who have mild encephalopathy, which we'll talk about in a second. It's cooling the entire body or the head down to 33.5 degrees Celsius for about 3 days. And then there's a rewarming period that lasts about 12 to 24 hours. It really must be initiated as soon as possible, preferably within the first 6 hours. And trials trying to extend it have demonstrated it's not quite as effective if you go past that and try to go into the first 24 hours. It requires some resource-intensive monitoring. So particularly during passive transport, you have to make sure you don't overcool children just by kind of letting them cool on their own. But also in many cases, it's recommended to have continuous electroencephalography, so EEG monitoring of the brain to look for any type of seizures. And that's really where my team generally ends up getting involved as the neurologist. It does have a series of complications to it that are important to recognize. It can lead to cardiovascular instability, decrease in platelet levels, or otherwise known as thrombocytopenia, as well as in rare cases, but with very painful cases, necrosis of the fat, particularly the back that's been laying on the cooling blanket. There have been increasing efforts to try to decrease some of these issues, as well as make sure that we can still increase the amount of time that families get to spend with the baby, even during the 3-day cooling period, including having programs now and type of cooling mechanisms where families can hold the babies to try to make sure that they also get the benefit of touch and of family bonding that should also be happening in the neonatal period. And so there's some important controversies that we should probably talk about in the course of what's going on with therapeutic hypothermia. The first question that came up and has been coming over the recent years has to do about where do we cool. So as I mentioned, this is a resource-intensive strategy that people have. And with that resource-intensive strategy, there was a trial that was done. It's called a HELIX trial. standing for hypothermia for moderate or severe neonatal encephalopathy in low and middle income countries. And I have just a sentence here that I took from the conclusions of the paper, where essentially therapeutic hypothermia did not improve outcomes of disability at 18 months after HIE. In fact, there was some concern that it might have actually increased the amount of death in these countries. Since then, there have been papers here that have suggested that, and abstracts that I've seen in meetings, for example, at a recent Newborn Brain Society meeting, that suggested that this might be something that's very context dependent. So this study was particularly done in Sri Lanka, Bangladesh, and India, and that potentially the context of what's going on with HIE in those populations is different, for example, of other low middle income countries, such as in Latin America. And so I think we still have a lot to learn about where HIE is, where therapeutic hypothermia is a safe and effective treatment for HIE. The other question is, when do you cool? And so there have been, as I mentioned, this is generally talked about in term infants. Well, all the initial studies focused on greater than 36 weeks gestation. And there have been multiple case series that have discussed potential safety in going lower, particularly down to all the way down to 33 weeks gestation. However, there have been initial reports that were last year presented as an abstract of the pediatric at the PAS conference for pediatrics that suggested that from the preemie hypothermia for neonatal encephalopathy study that suggested there could be a problem with actually increased mortality as well in the premature population. So I think this is something that we have to consider. As I mentioned, we talk about HIE mostly in term infants, but doesn't happen in preterm infants, and this might not be an effective therapy. And the last part is, who do you cool? And so I mentioned that there's criteria for whether or not people are mild, moderate, or severe when they're born. All the initial studies focused on moderate to severe, but there is a trial that is now ongoing that's trying to compare the effectiveness of cooling for mild encephalopathy. And that's something that is just starting, so it'll be a couple of years before we find out if it's an effective therapy also for mild, which I think will be somewhat more challenging in the sense that the early outcomes that people generally use, such as 18-month disability, are something that are generally normal in kids who have mild HIE. What we really are starting to see is that it's later outcomes that happen when children are in the more school age period that seem to have more significant, you start seeing them more significantly. So it's going to take a long time to really see if kids cooled now in the mild period are actually going to end up having a benefit in the future. And the last thing that we talk about when we talk about the treatments for HIE is really kind of supportive care. And that happens throughout the course of a lifetime, although we maybe don't think about it quite as much an important therapy, but I really do think it is. So in the NICU, there's the cardiovascular and respiratory support, particularly for kids who might have instability, managing any other complications that might have arisen for why they had HIE or anything else that had to do with the birth. If children are seizing, we provide anti-seizure medications as needed, the most common one being phenobarbital. But then after the NICU, there's an the rest of the life has to happen, and the rest of the supportive cares have to occur as well. And typically speaking, there could be a multidisciplinary team that's monitoring for outcomes. This also includes having early intervention therapy, such as physical therapy, occupational therapy, speech therapy, vision therapy, similar to what you might see in a premature population. Adaptive equipment as needed. If there's children who go on to develop epilepsy after the acute symptomatic seizures that we see with HIE, treating those seizures, as well as other things like tone management, for example. And then once they start to get older, trying to think about any sort of other learning issues that may be coming up as kids transition to school age as appropriate. So it really requires a lot of monitoring, and there's nothing that we necessarily can do to reverse any sort of difficulties, but we can support children through it and help them adapt as we do with other conditions. All right, so that's what we do now. So what are we going to do kind of going forward into the future? Or what are we trying to do now in the upcoming years to hopefully be able to expand upon our limited profiles? So the first thing I want to address was a trial that recently ended, which is the HEAL trial that people may have heard about. It stands for high-dose erythropoietin for asphyxia encephalopathy. It was a randomized double-blinded control trial. And here it administered within 26 hours a dose of EPO, as well as at 2, 3, and 7 days. And this was done with hypothermia, essentially targeting the secondary injury phase that I mentioned before. Unfortunately, and again, I put a line from the trial here, children, newborns who ended up getting EPO did not actually have an improvement benefit, and there was also concern for an increased rate of serious adverse events. And so that is not going to end up being something that we do in treatment. going forward. But it is a trial that we're still learning a lot from, and whether or not there are subgroups that might benefit from EPO in the future. So as far as trying to develop novel interventions, so what have people been trying to do? So essentially, the Gates Foundation and others have been part of this initiative to really understand whether or not we can apply medications that we already know and see if they have any kind of improvement towards helping with HIE. And particularly screening for applications, it might be easy to adapt to the low middle income population where, as we mentioned, therapeutic hypothermia is ineffective. And so essentially what we've taken is basically decades worth of basic science research, the literature screen for compounds that could be available widely and potentially at low cost, and then develop the platform where they can do multi-organism testing across different models of hypoxia to see if they were effective. This included using human organoids, which are basically little like grown in petri dish mini brains for those who haven't heard of it, rodent models of HIE, piglet models, as well as lamb models. And that has led to a couple of either the trials that already have just started or trials that are about to start, which I think is actually very exciting. So let's go through with some of the data from that. So this is a paper that looked at, and I don't know if you can use a pointer at all, but this is a paper that used the rat model of hypoxic ischemic encephalopathy to take a look at what's going on. And essentially in the red is basically a saline control group that didn't get any kind of medication at all, and they got hypoxia. And so that's the part that you can see the variability of injury that could occur with HIE, which is in some ways both frustrating, but also very much what we see in children. So I think really a good representative model in many ways because of that. And what this is looking is the amount of brain area volume that was lost. In the blue, if you can see it, there's actually a group that's actually got therapeutic hypothermia alone. And so essentially in comparing all these different compounds, what you want to see is that it has less brain area volume loss than the people than the rats that were in the blue. And there are a few different molecules that end up coming up. And I'm going to highlight two of those, caffeine and melatonin, which, as I'm sure many of you have heard of before, are actually widely in circulation, making them ideal candidates for potentially broad use. So the caffeine trial currently just went through, had published a phase 1 trial that looks like it's a safe thing to give in the neonatal period. It's again targeting the primary injury, the secondary injury phase, being given a dose within the first 26 hours, and then for another dose or two in the subsequent days. So far, it seems to be safe, and now it's going on to phase 2 trials to see if it's effective in decreasing HIE. So this is the period in which it's being given. The second one has been melatonin. And so melatonin seems to be just like hypothermia, most effective very early on, kind of really more in the latent window, if you will. This is a little bit skewed over to the side, but really between the primary and secondary injury phase to try to decrease the amount of injury going into the secondary phase. And so hopefully this is not too small for everyone to see, but basically there's lots of different mechanisms that potentially could be melatonin could be working on. And so I think that makes it an interesting kind of therapeutic in the sense that we're not trying to target one aspect of it, but it could be decreasing cell death. It could be trying to reduce that oxygen stress that I mentioned before, acting as an anti-inflammatory, as well as sort of just overall regulating gene expression that could be important for recovery of cells. And so that's something that is still very much in progress, but something that is, we'll see where it kind of goes from here on out. The last one I wanted to talk about, which was something that had come up sort of in discussions that Leah and I had, was the capacity for stem cells. And so there's been many trials in animal models trying to think about using stem cells to try to treat HIE. And I'm just going to focus on this particular version of stem cells, which are human umbilical cord-derived mesenchymal stem cells, otherwise known as MSCs. This particular study I'm going to show you right now is from the Robertson lab, where they used the piglet model of HIE. And essentially what they did is they caused HIE in a neonatal piglet. They cooled the piglet for the first day or so, or the first half day or so, and then they introduced giving MSCs either intranasally or intravenously to see if they could improve outcomes. And outcomes here are a little bit harder to measure because you can't keep a piglet alive for that much longer after the study, but mostly based on imaging markers as well as looking at the EEG patterns and any kind of cell death and pathology. And so I won't go through every part of this paper. I'll just kind of go through maybe one of the most striking figures that compared sort of the intravenous versus intranasal administration. And it turned out that intranasal, which is kind of, one more time, the time that we're trying to administer here is during the secondary injury phase to help with recovery and kind of this mitochondrial failure that's going out here. And so this is looking at the histology that came from this piglet model. I'm going to have you focus on the areas that have the 2 stars and a few stars on top of it. But essentially what you're seeing on the top part of the panel, when it's what's called tunnel staining, is looking for cell death. And when you end up seeing is in the intranasal MSCs, you end up having a pretty significant decrease in cell death in white matter regions, as well as a part of the brain that's called the internal capsule that we frequently do see a lot of cell death in kids in MRI scans. The second part we're showing you is that there seems to be a recovery of the white cells. And so one of the things that HIE is thought to do is affect the way that the white matter of the brain is differentiating and how it's being affected. And so you can see that there's an increase in white matter in the hippocampus, the periventricular white matter, as well as internal capsule that corresponds to the decrease in cell death. And so I think that gives some histological evidence that there's some protection happening because of the MSCs themselves. I have to say, this is one of those things that's actually, how exactly does this work? It's not like these cells are turning into neurons. So what exactly is happening? And there's been a bunch of mechanisms that have been proposed as far as it also being able to regulate the immune response and sort of make it less inflammatory of a response. Maybe the mesenchymal stem cells, which are providing growth factors that will support the growth of kind of new progenitor cells ongoing. And I think one of the most interesting one has to do with this mitochondrial nanotubes that you might see here on the side. And essentially what that is suggesting is that what the mesenchymal stem cells are doing are creating kind of these panels that can go these tubes that can go between the healthy mesenchymal cells onto the injured either glia or neurons, basically pass on healthy mitochondria. So basically go ahead and shuttle them into it in order to be able to kind of basically decrease that mitochondrial failure that's so important for the secondary injury phase. All right. So lastly, where does this leave us with the possibility of translational promise here? So I've been mentioning this throughout what these different injury phases kind of correspond to. And I mentioned the therapeutic hypothermia window in this latent phase. And the question is what opportunities we have to improve long-term outcomes. And that's the goal of all these therapies that I've presented, is to sort of basically decrease the amount of injury and have that lead to improved neurological outcomes overall. And so the question is, can we develop novel therapies to do this? And not novel therapies and maybe some novel therapies that will decrease the incidence of HIE, so we have just less patients overall, or be able to support women when they maybe have something acutely happen. Also, we've talked about lots of things that kind of really kind of address that latent and secondary injury phase, but really the interest of my lab has to do with whether or not we can improve the tertiary phase. And I don't particularly have any specific compound to show to you just yet that it works even in an animal model, but just want to give you a sense of how we're thinking about this. In the prenatal period, you end up having there's some kind of insult that leads to a baby that's sick. One thing that is true as a neurologist, and I'm sure is true of the neonatology community, is that sometimes hard to predict which children will go on to have typical development versus which ones might have a more severe neurological outcome. And part of it is because there's lots of different factors that have to do with what happens to a child, including the timing of the insult, how long, both during gestation as well as how long it's been lasting. There's also some kids who have different regions of the brain seem to be more affected than others. There's also multiple things that can happen simultaneously. So for example, if you have HIE in a premature baby that may also have inflammation, those are 2 separate things. And then, of course, during the course of lifespan, there's also a lot of other factors, many of which have to do with the environment, including socioeconomic status, which is by itself not a biological factor, but does have biological consequences. And so when we're thinking through what this could be at a molecular level, the way I sort of think about this is that you have a progenitor cell that's going to turn itself into a neuron, and it's just focused on neurons for now. And you might end up having when you have some kind of prenatal insult like hypoxia, you end up basically skewing the differentiation pathway. And even though it might be a short and brief period of time that the cell is exposed to something, it basically sends things somewhat off kilter where some of the cells will be able to recover, but some of them will not. And the question that we're currently investigating is how do we kind of translate these particular clinical observations of all the things that might end up affecting an injury, a prenatal injury, and how do we implement them into understanding the molecular effects? And so we have some ideas about how we're doing that, and hopefully in a few years, I will also have a new compound that we can go ahead and present to you as well. And so with that was a little bit of a tour de force to what's going on currently. But I hope I've shown you today that HIE has basically an evolving timeline. They need different therapies at different times to address different parts of the injury. Therapeutic hypothermia is useful, but it has some limitations in helping decrease disability after HIE, and some really important lasting questions about what is it that when it's most effective and where it's most effective that we still have to answer. There's some promising therapies in a pipeline based on preclinical studies for the primary and secondary phase that I think will be really important to kind of think about going forward, and hopefully be able to add on to this in the next year or two, so it's not just therapeutic hypothermia that's been approved. But really, my hope is that advances in molecular neuroscience are going to allow us to expand the window for methods for therapeutic window for HIE, and so that even if children aren't necessarily diagnosed early on, or if, for example, they don't have access to the resources needed to do intensive therapies in the first several hours, we still have options to be able to help them improve outcomes overall. And so with that, I want to thank you for your attention. This is where I work at CHOP, and this is my contact information for anyone who has any questions at all. Thank you so much, and happy to take any questions.
Thank you so much for that presentation. I definitely wasn't lying at the beginning when I said you have a lot of ground to cover. I feel like you were hitting everything. I was writing questions down, you were answering them. I was like, okay, this is great. It was a really comprehensive presentation.
Thank you.
My questions, I mean, they may, because I have very basic knowledge on all of this, but I'm wondering, is HIE something that you can predict ahead of time, or is it really just a spontaneous condition that people have to respond to?
It's really a little bit more of a response aspect of things. I think it's very challenging to be able to do the kind of we don't really have the monitoring that we need prenatally to be able to get to that. And some of the mechanisms, for example, a uterine rupture, a placental abruption, are things that happen just very acutely. And so it's really something we're unfortunately right now we're still more responding to than we are actually being able to first diagnose.
And would it be right to say that this seems to be like a newish category of study, that it's something, I mean, I know neonatology hasn't been around even that long, but in terms of like HIE and the specific, is it something that is fairly new?
No, I think it's something we've actually known about for a while. The initial, so the SARNAT score, which is a modified SARNAT score, is still what we use. Is I think I want to say over 50 years old, as far as being able to sort of characterize kids who've had it. It's gone through a lot of evolving names. So the first names were like perinatal asphyxia. There's a big controversy as to whether or not we should be calling it HIE versus neonatal encephalopathy due to HIE, and so there's been a lot of changes in the name of it, but as an entity, it's existed for quite a while.
And you mentioned in your presentation and before when we were chatting that it's usually easier to pick up in term babies. And is that because it can be hard to determine it was from HIE because preemies have other things going on?
Yeah, I think so. I think it's really a lot of it has to do with that, and I think the big part of it is that it also relies quite a bit on the clinical exam. And so by relying on the clinical exam, it's much harder to do a good clinical neurological exam on a preemie who has maybe other respiratory issues and other things that are kind of going on simultaneously. And so I think that really has some limitations. There's also some suggestion, in sometimes in the preemie literature, they're like, oh, it's okay that the kid might be acidotic down to 6.7 or something like that because they're preemies. It's not clear. I think that there's probably some suggestion that maybe that is a hypoxic aspect of it, but we just haven't been as systematic about being able to diagnose it. And again, because we're sort of relying very much on very fast and evolving clinical markers, it's a little bit hard to kind of tell. Mm-hmm. The other thing is that one of the things that we do in the term neonates, which I didn't talk about as far as its long-term diagnosis aspect of things, was that we usually do an MRI somewhere around day 3 to 5 of life, to be able to see the amount of injury that's happening. Now, that is not something we can routinely get on premature babies, especially depending on very premature babies, in the sense that they might not be stable enough to even take, and there's some also more limited understanding of what those MRIs should look like and how they might look like with the findings of hypoxia.
I'm going to fast forward a little bit to when you were talking about the stem cell research, because I think it's something a lot of people are interested in, and I think a lot of people are even holding their breath about for hope on this and what it can offer people. And so when you're talking about using the umbilical cord,
Mm-hmm.
and in this case with the piglets, was it something that it had to be that piglet's umbilical cord in order to use
No,
it? Or
it
you
was
just
human cells, actually. They gave it human cells.
okay.
Yeah. And so there's an interesting question.
Yeah,
I think initially when it was being developed, I do think it was sort of thought as like giving someone back their own stem cells. But
right,
I actually am not sure that would be quite as effective in the sense that those umbilical cells have also been going through HIE. There's something that caused the loss of oxygen and
right.
nutrients to the placenta, and so they may also be stressed out. And so, are those going to be the best ones if they come from you? And I think that's probably still an open question, but I think my understanding of the idea is that would actually be sort of more of a cord bank that would be providing these stem cells. So I think that there's a lot to still be worked out on that one, but I think it's actually something that is probably it's been. I showed the one study, but there's actually numerous studies about about its efficacy in preclinical models and trying to modify them to make them even more effective. And I think that with all of that, it really does suggest that there's a lot of hope that this could be something that's worthwhile. I think one other aspect of it that you may know that kind of made me breeze by a little bit in the piglet study is that the hypothermia period was pretty short, not the typical 3 days that we end up doing. And so I think that there's a couple of aspects that we're going to have to sort out is, are these stem cells as effective if they're cold and we're making the rest of the baby cold? And so I think there's still some little more legwork to kind of figure out with that. But and does that mean you should give them multiple times to sort of help with this phenomenon? But I think there's a lot of promise here.
Hmm. Why did you do why did the study do the shorter time with the?
That's a good question. I don't. I was as I was kind of reading through for the presentation, I was like, oh, that's shorter than I thought it was going to be.
Yeah,
It might be practical and just sort of the capacity for what you can actually accomplish in the lab versus what you can do in life.
right. And I loved what you were talking about with the melatonin affecting all the different kind of areas, because I think a lot of times we look at treatment as being, yeah, we'll treat this one thing,
Mm-hmm.
but there's so many, especially with prematurity and with the condition of HIE too, that it's a domino effect on our system. So when you were talking about that, I was like, yes, those are the kind of solutions we even have to be looking at to troubleshoot.
I agree. I mean, I think that the reality is that HIE or prematurity or infection or any of these other things, they don't hit one pathway. They hit lots of pathways. And
Mm-hmm.
therefore, we have to hit lots of pathways to recover. Like, we can't expect that's going to be a single solution. And that's why I don't think it's even going to be a single compound. I think it's going to have to be the strategy where we're thinking about where are we in the course of injury and how can we adapt to be able to help support that particular part better.
Mm-hmm. Now, you talked a lot about long-term outcomes, and I know that NICU parents always talk about long-term outcomes. That's kind of our reality of you leave NICU and then you have a full life afterward where you are always asking yourself what those long-term outcomes are going to be. And I know that we don't have the crystal balls to tell us the future, but I'm just wondering, in your studies and in your lab, how far do you follow babies who have been affected by HIE?
Yeah, so the majority of my lab work is actually right now still in animals. But the way that
Mm-hmm.
we've been structuring our studies is to actually try to look at what happens in the adult animals after prenatal hypoxia. And the reason for that is very specifically because we care about long-term outcomes. And so the way that we've been doing this is we have a model of mild HIE actually in the lab,
Mm-hmm.
where we decrease oxygen down to 5% in a pregnant mouse and just sort of let her have pups. And it turns out that early on, there's very little differences and there's not very much cell death in the brain. But when you look in older animals, if you give them an insult that causes a seizure, they seize much faster. If you do behavior experiments on them, they have problems with anxiety and sort of repetitive behaviors. And so that suggests kind of it's a milder phenotype than that. And they also have some weakness in the legs, kind of suggestive of cerebral palsy. And so these are all just proxies, obviously, because a mouse is not a child, but it does give us a sense of that even a short exposure before the pups are even born can have these long-term effects. And so the way we've been addressing that now is trying to see, okay, we looked right after the injury to see what the molecular markers of injury are. And what we're currently actively doing is now looking at, okay, let's look a month after the injury when technically it's a teenage mouse, and see what those markers of injury that are left still are. And our hope is that out of that will emerge some kind of clinical factor that we can manipulate throughout that first month of life. That would be akin to manipulating in the first years of life in a child, that might be able to help outcomes. My lab in particular is focused on trying to understand things like, it's called the epigenome, which is sort of the code of, you have your DNA that tells you that encodes all the genes, and epigenome is sort of like the light switch box at which genes turn on and off at the right time during development. And so my lab is focused on maybe hypoxia is turning things on or off at the wrong time. And can we sort of reset that light box in a way that actually lets us develop more normally? So that's the approach that we're taking. As I say, I don't have a particular pathway or marker yet, but hopefully by thinking about that, we have something that is useful not just in the first few days of life, but also something that can be used at 3 months of life, a year of life, something that, across the board. So I think I agree. I think there's an entire other lifetime after you all leave the NICU. And so we have to also adapt to the rest of your lifetime and help you there too.
Well, thank you so much. It's very interesting. And I think the main thing that I take away from your presentation and from what you were sharing is the hope of, this is something that's evolving, and something that as people like yourself are studying and researching and looking at those long-term outcomes that we value so much, that it just brings hope for the future of our babies who may have HIE. So thank you so much for your work, and you're sharing your knowledge with us, and for being here with us today.
Thank you so much for the invitation. It's such a pleasure. And if anyone has any questions, I'm always happy to discuss further. And if anyone has any ideas, I'm also happy to discuss further, because I think that some of the best ideas come from parents. So I'm happy to chat about that too.
Thank you again.
Take care.
And thank you everyone for joining us for this edition of Preemie Chats. A special thank you to AstraZeneca. They have support us for all of our educational programs, such as this one. And so we're really thankful for them. And just a reminder that if you did miss any part of today's session, then you can head over to canadianpreemies.org. And there you will see this episode and all past episodes of Preemie Chats. And there you'll also find many resources and support options available. You'll also be reminded that CPBF is a charitable organization, and it depends on support to continue its very important work. And so as you go to canadianpreemies.org, I did just ask you to consider how you fit into the landscape of all that Canadian Preemies Foundation is doing, and how you can help empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. I hope that you're available to join us here next Friday at 1 p.m. Eastern Time. It is our Kangaroo Care Day special. And I had a sneak preview last week of one of our presenters, and you're not going to want to miss it. It is an amazing presentation on the best interventions NICU babies can have. And so I hope you're able to join us next week for that. In the meantime,